Hi guys, we're gonna go ahead and get started today. We're just right at the top of the hour. So welcome in wherever you guys are joining from. I'm out here in the cold, so we actually got some snow this morning, which it has been a pretty dry winter so far, so I shouldn't complain, but I'm originally from the desert, so my toes are cold. So you guys can go ahead and drop in the comments where you're joining from. It's always fun to see how many nursing students we have joining from all over the world. I love that. Nursing obviously is my passion, so we will go ahead and dive in to what we're talking about today. I love teaching webinars because I helped make Archer for Nursing School, which if you guys are new and this is a product you haven't heard a lot about yet, this is the most comprehensive, all-inclusive package that you guys can get as nursing students. I know we've got Jennifer, we've got Diane on the call. They're helping out in chat, so be patient with them if you have any questions. They will help answer them as soon as they can. But they're both nurses. I'm a nurse. Jennifer and I both went to grad school. We're both nurse practitioners. So nursing is our entire life. And with that, it means we have been in your shoes. I was just asking in, our work group chat yesterday for people to send me in some pictures of them in nursing school. Just because I was like, I think it really makes us a little bit more relatable, guys. Like, I think sometimes we can feel a lot older than they are, but I mean, I did nursing school, Jennifer did nursing school, Dan didn't. We all went to school, and I remember how hard it was. It's definitely a big learning curve with nursing school. There's so much to remember. I just remember it being like this fire hose of information where, you think you've got a grip on it, and then all of a sudden, oh, you've got another 3 hour lecture and it's a whole nother dump of information. And then it starts to be like, well, I can't remember all of this. So how do I pick and choose what I need to remember and what I don't? And you can get really overwhelmed, especially when professors, they don't have time to cover everything in class. So then they send you home with hundreds of pages of textbook reading. I have never been a good textbook reader. That is simply not the way that I learn. And so we all came together and we said, what can we do to make nursing school a little bit easier, a little bit better to help nursing students out? Obviously, at Archer Review, our number one goal is your guys' success. I mean, it's why I love working at this company. You will never see a company that cares as much about their students as we do. And so with that, we have built you this comprehensive course. There's 20 full courses. We just last week launched our clinical skills course, which is really exciting. Morgan Taylor and I recorded over 200 clinical skills for you guys. So putting in an IV, and then even simple stuff like burping an IV bag. I was never taught how to burp an IV bag. And then all of a sudden you show up at clinicals and it's like, well, everyone burps an IV bag. Everyone's doing it. So you should know how to do it. And so that was really stressful to me. So we included that. We included a bunch of tips and tricks. And so that's the 20th of our courses. It really covers everything. When you're in peds, you can take the Archer for Nursing School peds course. When you're in fundamentals, you can take the Archer Review for Fundamentals course. So it really covers everything for you guys. And with that, we've broken everything up into really small lectures. So there's over 1,000 of these tiny little lectures just to cover things in little bite-sized pieces so it doesn't feel so overwhelming. So while heart failure is a huge topic, all encompassing, you can go ahead and watch, one 3-minute video on symptoms of heart failure, and then another 5-minute video on pharmacological interventions for heart failure. And so we've really broken it down to make it more manageable for you guys. And then once you've learned that, we all know research shows the best way to make sure you remember what you're taught is to practice, practice, practice. And so we have over 5,000 practice questions in our Q bank. And this is different than our NCLEX because we know Archer Review has an awesome NCLEX product. It's one of the places we really, really shine. And that Q bank is really robust. There's all those questions in that Q bank. And now here you have another 5,000 questions to, review and learn from. And with that, over 200 cheat sheets. And I should have included a picture of a cheat sheet here for you. If you guys comment down below, we can go ahead and send you a link for some examples that are downloadable and free. Our cheat sheets are these 1-page illustrated documents. We have a medical illustrator who really summarized the most important information. I have graduated from grad school and I printed out all the cheat sheets and I keep them in a little binder laminated because I'm old and that's the way that I like to learn. And so I can just flip through those really easy and it shows me those must-know pieces of information. So with that, one of our courses in this 20-course Archer Review for Nursing School is our geriatrics course. And with geriatrics, that's my bread and butter. I minored in geriatrics in my undergrad. And then I also emphasized, diabetes and senior management and care in my doctoral program. And so I love the elderly. And with that, there is this group of disorders that are actually really common, not only just in our elderly population, but also just all of our patients, every one of our clients is at risk, especially if they're in a inpatient setting for what we call the triple D or any one of these Ds. The triple D is this group of neurocognitive disorders that I like to talk about at one time, even though they're very different, because students can really easily get them mixed up. I know you're probably thinking, Annie, that's crazy. Depression is so different than dementia. You would never get that confused. In real life situations, when you're caring for a client, those are very easily mixed up, which I know may sound surprising, but they have a lot of the same key features and they have a lot of the same symptoms. They can even go hand in hand. So you can have a client who is struggling with dementia, but also at the same time really struggling with depression. And remember, we care as nurses for our clients the most holistically way possible. So with that, that means that we want to make sure that we are covering all of our bases and taking care of our clients in the best way possible. We don't want to miss anything. So we're going to cover in detail these 3 Ds of neurocognitive disorders. With that, we have dementia, delirium, and depression. I would say if you're talking about older clients, delirium is going to be one of the number one things you'll see. And that we'll talk about that pretty in depth. Um, Sorry, dementia, I mean. In older clients, dementia is what's really, really common. You'll see that in a lot of older adults. My uncle who was a doctor when I was a kid used to always joke that there's a couple things that are guaranteed in life if you live long enough. Cancer and dementia. And so, there's not really research to support that. So don't go quoting that around. But he is right in that it is highly prevalent in our older adults. So every year that we live, our risk increases for dementia. And so you're going to see it most commonly in older adults. That's not to say that you won't see it in younger patients, younger clients. I actually care for a 25-year-old who had a stroke and now is suffering from a version of dementia because of their stroke. And we'll talk about that a little bit later on. But so don't just typecast it, that you have to be over 70 years old to have dementia, but that is going to be the population it's most commonly seen in. Delirium and depression, those are the two that I say across the board can be found in every single age group. And I think especially with depression, we are noticing that more and more, that it is more common in individuals in every age group. You're starting to see 10-year-olds, 12-year-olds that are struggling with depression. And in an inpatient setting, anyone who's sick is at high risk for delirium. So some of the key features, dementia is going to be a progressive decline. So my memory cue for that is dementia, I think decline. So that is going to just be something where they progressively get worse. They don't get better. They may have some days that are better than others. So it may feel like, oh, we got a little bump in the hill, got a little better. We're going uphill. But then the next day, it's just back to the way it was. And it will overall, if you look at that trend, it will be moving from upper left to lower right. So they're going downhill. The 2 primary causes of that are going to be Alzheimer's and vascular dementia. We'll talk about those 2 different types in just a second. Delirium, the key feature of that is going to be sudden. So while dementia is going to be progressive, delirium, that's going to be that big switch where people are like, what the heck happened? They're way different than they normally are. This isn't the mom, the grandma, the sibling that I know and love. This is weird. That is usually going to be caused by acute illnesses, infections. Even certain medications can really make us delirious. And that's why medication safety as nurses is so important and why we cover symptoms, because we want to know what a client's on and what the risks are associated with what they're on. So just remember, delirium, drastic onset. It comes on quick and it can get better really quick. It's reversible. That's why I said that clients that are in an inpatient setting are all considered at risk for delirium, because anyone who has an acute illness, an infection, or is on any sort of medication can be at risk for delirium. So that's why we watch for this, we monitor, we assess in all of our clients that are inpatient to make sure that nothing's changing and their mental status, their neurocognitive status is still there. Lastly, we have depression. That's going to be more of a persistent low mood. And I know depression can be a bit of a downer to talk about. There's a lot of things you don't want to be uncomfortable. If anyone struggles with depression and they feel like, they're reaching their wits end, they just don't know what else to do, I highly, highly suggest get help, reach out to someone. I know winter can be really hard, especially if you live in a dark, cold climate. When you miss the sunshine, I really miss the sunshine right now. But if it feels more than that, get help, reach out to someone. There's a lot of different places on campus, online, free resources for you guys that can help with that. That can be due to chemical imbalances. There's more research. I know we used to just say that depression was just something, oh, get over it, try harder, be happier, you know. And that can help, There are things we can do to help depression, but we have shown scientifically that depression can be a chemical imbalance that isn't an individual's fault. It's something that is happening in their brain that they don't have a lot of control over. But also, depression can be situational. So don't think just because you may feel depressed or your client's depressed. That's something I tell my clients all the time when I talk about depression or I screen for depression. Screening for depression, that's one of my big soapboxes. You never want to miss a client that's depressed. So I always screen for it. I always ask my questions, if they're feeling suicidal, if they're struggling with low mood, if things that used to be fun for them are no longer fun. That's all really important stuff to ask your clients. So I always cover that. But I always, always reassure my clients that depression doesn't have to be a lifelong thing. Just because you say, right now I'm struggling with depression does not mean that they're going to struggle with depression forever. A lot of times it's situational. Your dad just died of cancer. You got in a car accident and you're having a lot of low back pain. You lost your dog. You got an F on your fundamentals test. That would put me into a persistent low mood for at least a few weeks. And so it's understandable when things happen in someone's life, a stressor occurs, for there to be a mood shift. But we still monitor it and we want to make sure that we don't miss other things that may be underlying, like delirium or dementia. And that's why we're covering all three of these at the same time. So, first off, we're going to talk about dementia and the two major types. I know I said just a bit ago that dementia we often break into Alzheimer's disease and vascular dementia. I don't want you guys to take away from this that those are the only two types of dementia out there. There are a lot of different types of dementia. And so don't get confused. These are the two most common types. And so I like to cover them. Alzheimer's disease, I would put good money that every single one of you guys in this chat today has heard of Alzheimer's disease. It is highly prevalent. It's increasing. There's more research being done on it. It's often just used colloquially as the term dementia. People say, oh, my grandma has Alzheimer's. Well, it may be a different type. We don't super know. Alzheimer's, the major symptoms with that are going to be memory loss, language issues, and then lastly, disorientation. So it's going to just be this, as we said earlier, this progressive decline where they just get worse and worse and they'll start to forget more things. Sometimes they'll even have language issues. I think that's one I included in here because it's less well known, but it is very common symptom. So all of a sudden they have a hard time speaking, and they can have different types of aphasias where, they're saying a lot of words, but none of them make sense, kind of like a toddler who's learning to speak, or they may be saying words that make sense, but like not in the context that you guys are having a conversation, if that makes sense. And then disoriented. A lot of times we'll call it on our floors a silver alert, which means, a geriatric client has gone missing or has wandered. They can get really disoriented and not know where they are. And that can be really scary. So that's something we want to monitor and make sure we have safety precautions in place. The main cause of Alzheimer's, and I will not get too much into pathophysiology about this because there's more and more research outcoming, and I don't want anyone to say, oh, Annie didn't know what she was talking about, a decade down the road when we find out something different. But as of right now, what we know is that in clients with Alzheimer's disease or Alzheimer's dementia, they have this accumulation of something called beta amyloid plaques. And they have these things called neurofibrillary tangles. And I cannot really explain that super well for you guys, other than the way that I like to think of it is, that your brain has all of these fibrous connections that, are all talking to each other simultaneously. It's what makes humans so amazing that we can do so much. We have so many neurons constantly firing and impulses going down the wavelengths. In clients that have Alzheimer's disease, they start to have these plaques that grab onto those those neuro pathways and they block them. So all of a sudden things aren't transmitting very well. And then you get these tangles. And I like to think of that as if you've ever seen like a power line after a hurricane or something and they're broken and they're all wiggled around and they cause a big tangle, it impedes traffic. So all of a sudden these neural connections cannot move down that pathway anymore and individuals' brains just don't work like they used to. And so that is going to be your main cause, the pathophysiology there behind Alzheimer's disease. Vascular dementia, another type of dementia. So a lot of the symptoms are going to be the same. They're going to have memory loss. They may have language issues. They're going to be disoriented. The difference here is the cause. So just like in Alzheimer's disease, you're going to see a stepwise decline. With vascular dementia, you're going to see that same stepwise decline, but it usually follows a stroke. So this is going to be someone who, like I was talking about, my 25-year-old patient had a stroke really young. A hemorrhagic stroke just happened after a car accident, like a week or two later. That stroke caused reduced blood flow to the brain. And remember, all of our organs need oxygen to survive. So they went long enough without oxygen that then caused just their brain to not work as well. They now have lasting damage due to that hypoxemia that lasted a set length of time, a long enough amount of time that it has caused lasting brain issues. And so that is going to be vascular dementia. But just to say, it doesn't have to be a stroke. That's usually the most common cause of vascular dementia. But I do see a lot of clients that have vascular dementia because of things like long-term hypertension or heart failure, where the brain's just not getting enough oxygen long-term. So it wasn't just a one-time stroke where they didn't get any oxygen for 10 minutes, but instead, a consistent progression of untreated hypertension, something like that. So with dementia nursing interventions, because obviously now you're able to differentiate between a couple types of dementia, you know the main symptoms. What can we do as nurses to take care of our clients that have dementia? Well, these are kind of the big three I think we want to focus on. Obviously, there's a ton more that you can get into, but really the major three are behavioral management, physical care, and then safety measures. So you want to make sure that we are covering those with every single one of your clients that has dementia or that may even you think have dementia. With behavioral management, you want to make sure that you have routines. One of the biggest things, the reason we kind of do everything else, like why we do physical care and why we do behavioral management, ends up being a safety measure because we worry about our client's safety when they start to forget things, when they become disoriented. For example, a client that takes medication that needs to be taken on time every single day, imagine now that that same client has severe dementia. They can't remember to take that pill. They may take it twice, which could be really dangerous when we're talking about things like opioids. Imagine your client just keeps taking an opioid because they don't know that they've already taken their dose. Next thing you know, they could have respiratory depression. And so with that, we want routines and memory aids. We want things like medicine boxes or an aide that administers medication. We don't want them managing that themselves. That is a safety issue. Calendars are awesome. Labels are awesome. I'm really big on labels and really big labels, especially if your dementia client also has, bad eyesight. You want to make sure that they are able to easily see, easily read, and get that constant, remembrance of like, oh, this is my name. Oh, this is the expiration date on this food. That's actually really surprising. Working in geriatrics, one of the things that my clients struggle with the most that have severe dementia and are still trying to live on their own is eating expired food, which you would think, well, they could just read an expiration date. But oftentimes, if imagine, I just went to the grocery store today, actually. So I went to the grocery store, I grabbed a carton of milk. I'm not going to check that expiration date on my milk for at least a couple days because I know I just bought it. So my assumption there is that the milk is good for me to drink. Older clients that have dementia have a lot of that same, they don't remember, they think they just went grocery shopping, they think they just made that chicken dish, things will last in their fridge for a long time, and then they're eating things, they're getting food poisoning. I mean, I think I have in the last year, I had at least 15 older adult clients that had food poisoning from eating expired food. It's crazy. So we want to make sure that we are educating on that for when they're in a home or outpatient setting. Also, we want to distract them and redirect them. I know that there's a lot of different ideas on the best way to handle a client who has dementia and, for example, thinks that it's 1960. Do you pretend it's 1960? Do you pretend to be their wife that's passed? What do you do? What's going to be the best thing to do? Current research shows the best nursing intervention there is to distract them and redirect them. To just like come right out and say, hey, sorry, Jennifer, I'm not your husband, he's dead, can be a little jarring, especially if that is the time period they think they're in. It can really cause a lot of agitation. So instead, we redirect them and distract them. So we try to change the subject, we try to redirect their thing. It may be a puzzle, it may be a game to play. That's going to be your best bet for dealing with a client who is disoriented. Physical care, you want to encourage mobility. I think as nurses, a disservice we can do to our clients sometimes is we get in this mindset that is, they have another underlying condition, and so they're fragile, they're crippled, they need to stay in bed. My sister just got her gallbladder out, and my grandma, bless her sweet soul, a gallbladder, that's an outpatient surgery. They want you up and walking like 30 minutes later, really. The next day, my grandma saw my sister and she was like, oh, Allison, you're never going to heal now. You're supposed to be in bed. You need to be tucked in bed until you heal. That is an old idea that, when we're sick, we lay in bed and we get better. That's not to say that sometimes people don't need downtime, that it may not be safer to keep them in bed sometimes, but people that stay in bed die in bed, as my grandpa says. That is a Grandpa Caffrey quote. He always says that. People die in bed. And so you want to make sure that your clients are getting up, getting out, and exercising. We want to prevent deconditioning, which is that, constant decline of the body when we're not using it. Use it or lose it. If they're not using their muscles, if they're not using their brain, it will deteriorate. And that's going to increase their risk for falls and pneumonia and aspiration and all sorts of other illnesses. So we want to make sure that even in our clients with severe dementia, we're encouraging mobility and we're getting them up and moving. We also want to check for those signs of malnutrition and dehydration. They need to be weighed frequently. They need to be consistently reminded to drink water. They may not get thirsty like they used to. And we know that in older adults, that receptor that says we're thirsty diminishes. So they don't feel as hungry and they're not as thirsty, but they still need nutrients. They still need calories, just like every other human being. And so we want to make sure that we're pushing fluids and we're pushing meals to make sure they're getting enough for their bodies. So that's going to be important. Remember, I said these triple Ds we're talking about. Dementia, delirium, and depression all can go hand in hand. A client with dementia that becomes dehydrated and malnourished is extra high at risk for delirium. So we want to make sure that we are watching that and that we prevent dementia from becoming dementia and delirium. Lastly, safety measures. Safety measures, like I said, kind of encompasses every nursing intervention we do for dementia. Safety is our number one priority as nurses. We're trying to keep our clients safe. You want to lock up hazards, check expiration dates, and fall prevention. I know we already talked about expiration dates, so I won't touch on that again, but fall prevention is really important, especially because we talk about deconditioning and decreased mobility. You want to make sure that if they need a walker, they're using a walker. Clients that have dementia that think they're 20 years old don't want to use a walker. Have you ever tried in a clinical, if you guys are in your clinicals now on the floor, to get a patient or a client with dementia to use their walker? They're like, I don't need that. I'm not old bones. And so we have to try to find ways to redirect to get them to use their walker. Sometimes I'll make it a fun game. I'll use one too because I look young enough that they're like, oh man, Annie's using one. I can use one too. It's okay. We want to prevent falls to keep them safe. Then let's jump to a practice question. So we've kind of talked, I know I've blabbered on a long time about dementia. So now I want to see if you guys really have taken anything away, if you've got it. So you guys can go ahead and comment down below your answers. We'll go over this question first. A client with Alzheimer's disease is found wandering the hallways at night. What is the nurse's priority intervention? A, administer a PRN or as needed sedative. B, use a calm voice and guide them back to their room. C, place them in restraints to ensure safety. Or D, turn off hallway lights to reduce stimulation. So go ahead and in your chats, drop your guys' answers. I'm seeing a couple good answers, guys. B seems pretty common. Use a calm voice and guide them back to their room. It's great. Let's see. Give you guys just a few more seconds to get your answers in. Perfect. The correct answer is B. Using a calm voice and guiding them back to their room, that's a version of redirection like we talked about. That's going to promote safety. And remember, safety is always a nurse's number one priority, and it's not going to escalate their confusion. Remember, restraints are something that we want to use last resort, meaning you have tried everything. The client is a risk to themselves and they're a risk to other people. That is going to be when restraints are appropriate. That's not to say that restraints are never appropriate in dementia, but I try my darndest as a nurse to have tried every other thing I can before I use restraints. Restraints can be highly, what's the word I'm looking for? Stressful. They can be highly stressful to clients, any client really, especially clients with dementia. Same with PRN sedatives. Just giving a sedative because a client's confused or they're agitated, that's actually not really legal. You need grounds more than they're just being confused to just give a sedative. That is a chemical restraint. So we have mechanical and chemical restraints. You don't just ever give a sedative. So we know that one's not a right answer. We know placing them in restraints is not a right answer. Turn off hallway lights to reduce stimulation. That's a really good answer, actually. That's something that I would recommend we do. Just remember the question here was, what is their priority intervention? And on these type of questions, when we're talking about priority, I like to emphasize that word priority and then look at what would you do first. That's what priority means. All of these answers could have been correct theoretically. And when someone asks a priority question, you have to determine as the nurse what you're going to do first. And redirection and safety is always what we do first, followed by things like reducing stimulation. Great job, guys. We're moving on to the second of our triple Ds, delirium. Key features of delirium, remember, that is that drastic onset. Delirium, drastic onset. This is going to be when you have someone say, I don't get it. They were fine yesterday. That is my biggest indicator. I hear that, and there are alarm bells going off all over my head saying, this client may have delirium. That is really big. It's going to be that sudden onset and fluctuations in severity where, they may have a moment of clarity and then all of a sudden the next thing they're talking in another language. They're talking about things that happened 20 years ago. And, they don't have a diagnosis of dementia. They don't have any other issues. And all of a sudden you're like, whoa, what happened to grandma? Grandma was fine. And now all of a sudden she seems off. Remember, delirium also can manifest as a change of personality that's quiet. So I think delirium can sometimes get missed when someone's like, well, I mean, I didn't notice anything super off. She just was kind of tired, not super chatty, not really in the conversation at all. That can also be, a decrease in cognitive function. Neurocognitive function doesn't always have to be, whoa, all of a sudden they're bouncing off the wall, speaking in another language, crazy. It can also just be this change in mood where they're not invested in the conversation. They don't understand. They seem confused. They seem checked out of it. You'd also want to monitor and assess clients for delirium that have that. Common causes, like we talked about, infections, UTIs. Oh my goodness. I cannot talk enough about UTIs and delirium. In a client over the age of 70, I swear, if they have a UTI, they're having delirium. It goes hand in hand. In fact, the number one manifestation of a UTI in an older adult is often delirium. That will be the very first thing you notice. They won't complain of urine symptoms. So it doesn't burn to pee. Their urine doesn't smell weird. They're not urinating more. The only symptom you may have at the beginning stages is that they just seem a little off personality-wise. And so that's something we always want to monitor for. If you have a client, I'll talk to the provider and I will try to get a urine sample done because that is very high risk. Pneumonia, also very common, but I would say UTI is even more common. Medications like anticholinergics and opioids both are known for causing delirium in clients of all ages. So if you have a client that seems a little off, I would reconcile their medication list, see what they're on, see the doses they're on. Often you don't have to entirely stop the medication, although we do frequently do that. The provider will order, we're switching medications, we don't want them on that. Sometimes it just needs a decrease in dose. And I know you guys may be thinking to me, Annie, I'm a nurse. That's not in my scope of practice. I don't do that. That's true. You don't prescribe medication. You're not making the judgment calls on dosing. However, nurses are always on the front lines. Never forget that. Never underplay your importance. We are the front line. We're the ones seeing the clients on a more frequent basis. We're going to be the ones reporting to a provider that, hey, I recommend that maybe we decrease the dose of the opioids Since starting it, Jennifer has seemed really confused. She's not as engaged in the conversation, and I found her wandering the halls. That's going to be something a nurse found and recommended to a provider more than a provider just randomly pulling out of a hat the idea that, hey, you know what? Maybe we go down in dose. So don't underplay your importance. Then we have electrolyte imbalances. That's another one why I said we have to monitor for malnutrition and dehydration in older adults so dementia doesn't progress to delirium. Same thing. Any client that has electrolyte imbalances, really common after marathons, after big, fitness classes, they'll have gotten really dehydrated. If they don't hydrate enough, replace that salt, replace the potassium, they can get really confused and out of it. That may be a symptom that someone needs what we call a banana bag or just IV fluids of any kind. Here is the memory cue. Delirium causes is highly tested on the NCLEX. They really like this one of like what could cause delirium. So those drugs, infections, metabolic things we talked about, like diabetes insipidus, diabetic ketoacidosis. When you have a diabetic client whose blood sugars are in the 400, that can cause delirium as well. So I like to think dime. They can flip on a dime. That's a phrase. I don't know if I'm an old person, and so that's a phrase I know and you guys don't know it. But my parents say that a lot. Oh man, it changed, the stock market flipped on a dime. Your opinion changed on a dime. It means it changed really quick, which remember we say delirium, drastic onset. And so with that, these are the 4 causes: drugs, infections, metabolic disorders, and electrolyte imbalances that are most commonly causing delirium in clients. So nursing interventions for delirium, what are we going to do? Once again, safety, always our number 1 priority as a nurse. With that, I said that delirium is reversible. And I stand by that. Delirium in almost every single case is something we can reverse if we identify and treat the underlying cause. And this is why being a nurse is super important. It's one of our roles. Assessment. Assessment, assessment, assessment. It's the first thing we do. We love assessing our clients. So assess them, find that shift, and see if you can identify what you think may be wrong. We may end up getting urine samples, doing urinalysis, getting a chest x-ray to check for pneumonia. We may end up reconciling their medication list to see what doses they're on. With that, then, we want to report our findings to our provider. So whether that's a call, it's a page, it's an email, however you best talk to your provider on your floor, you'll find that out. It's going to vary, facility by facility. You want to immediately report any changes so that they can intervene quickly. Then you want to treat that. So this obviously is going to be where a provider comes in when there's orders. But like hypoxia can even cause delirium in some clients that are really anxious, that are having a pulmonary embolism. You as a nurse can put a client on oxygen if you feel it's an emergency situation and they need to be on oxygen. You can get that started. And so make sure that you're looking at what you think is going to fix that issue, and that we are implementing that as soon as possible. Looking at safety precautions. Fall risks. Clients that have delirium or are suffering with delirium are very high fall risks because they're so disoriented. So they're big wanderers. They can get lost. They can trip. Any client that has delirium, their bed always needs to be put in the lowest position. We need to make sure they have adequate lighting so they don't get confused or scared, and that you have removed hazards from the room. Supervision is often needed. A lot of times you'll do what we call a one-on-one or maybe a two-on-one, where someone even sits in the room and watches the client the whole time because they're that much of a safety risk and we don't want them to hurt themselves or anyone else. And just like with dementia, we always avoid restraints whenever possible. So restraints are a last-ditch effort, especially because we talked about for all this time, the delirium is treatable. And so really putting restraints on your client isn't going to treat anything. It's not going to fix their pneumonia. It's not going to fix their UTI. And so we really try to do that as a last ditch effort. Here's your practice question for delirium now. A client is admitted with confusion. What are you guys thinking? Oh, I wish I could cover that up. Your first thought should have been, oh, I wonder if they have a UTI because they have confusion. What is going to be your priority intervention? There's that word again in this practice question, priority intervention. So some of these may be more than one of these may be right. What are you going to do first? So go ahead and drop in the chat below. A, provide a quiet room with low lighting. B, administer the antibiotics they've been prescribed. C, use restraints to prevent falls. Or D, monitor for worsening confusion. Woohoo, guys, this is a tricky one. I am excited to see what you guys drop in the chats down below. What is the right answer? Go ahead and put your answers below, and I'll give you just another minute to answer it, and then we'll cover the rationales. I'm seeing some B's. Once again, administer antibiotics as prescribed. Well, let's see. Ding, ding, ding. Administer antibiotics as prescribed is the correct answer. And I thought this one may trip some of you guys up, but obviously I'm doing a very good job teaching, and you guys are very smart because no one got this one wrong. B is the number one thing you're going to do. It's the priority. Providing a quiet room with low lighting? Well, providing a quiet room, correct. Low lighting, oof, that's wrong. Remember, we want adequate lighting so that they can see. Low lighting can worsen delirium. So we can already write that one off as, phew, that's wrong. But it's kind of tricky because sometimes on the NCLEX, they like to put a question, an answer to a question that, part of it is right. And then it's just the last little bit that's wrong. Me, I'm a skimmer. And it's one of my big faults, especially when taking a test, is I skim answers too often. And I'm like, oh yeah, provide a quiet room. Yeah, I read that. That's right. And then I missed the low lighting, which is what we want to avoid. So that one we got rid of. C, use restraints to prevent falls. Oh, remember, we don't really want to use restraints unless absolutely necessary. It will worsen the delirium. So we can get rid of that one. And then D, monitor for worsening confusion. Well, yeah, we want to do that. Nurses love assessment. We always say assessment, assessment, assessment first. So why is the right answer administering antibiotics? That's because the first thing you do with delirium is you treat the underlying infection. If we've already identified that there's a UTI and they've already been prescribed an antibiotic, we want to make sure that that is getting to them so that their body can fight that infection, because that is going to be the only way to actually fix or cure that delirium. Good job, guys. I'm really proud of you. That was awesome. Okay, lastly, the last of the triple Ds, depression. I skipped one. My slides are backwards. Ignore that. Okay. Key features of depression. A persistent low mood. Remember I said depression, I can be dramatic sometimes, and my family says it's one of my worst traits, but I think it honestly keeps things spicy around the home and with all my friends, where it's like, something goes wrong and you joke and you just say, "Oh, that is just done me in for the day. I'm developing depression." I mean, I ran out of M&Ms last week and that's how I felt. But to actually have diagnosable depression, what we're looking for is a persistent low mood. It's not that someone said something mean to you in class and it hurt your feelings for a little bit. It's not that you ran out of M&Ms. It's not that, you broke a toenail or a fingernail. It is a persistent low mood. This is a diagnosable issue on the DSM-5 that clients for at least 2 weeks have this group of symptoms, and that group of symptoms can include fatigue, appetite changes, sleep disturbances, thoughts of self-harm, thoughts you're better off dead, feeling like you're not enough for your family, like you're a failure. There's a whole thing. It's called the PHQ-9. It's a screening tool. And one of our webinars in the next couple months, we're actually going to go over some of my favorite screening tools, because I know those can feel overwhelming. There's a lot of different types. But PHQ-9 is specifically for depression. It's very commonly used. There's also a PHQ-2, which is similar, but it focuses in just on these two main questions. Have you lost interest in activities you used to like doing? And have you had thoughts that you're better off dead? It tries to really cover the most overarching aspect of depression. Either way, any of the depression screening tools that we're using, as we use them, we repeatedly ask, in the last 2 weeks, blah, 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 blah. In the last 2 weeks, blah, 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 blah. What you're searching for here is for that persistence. You're trying to search in the fact that it's, they're here today getting a colonoscopy. Like, no one's in a good mood about getting a okay, no one's probably an exaggeration. I'm sure some people really are. But most people are not in a good mood getting a colonoscopy. No one's excited to get scoped. And so, screening just that one point in time is not a very good indicator of whether or not a client is struggling with depression. So remember, symptoms need to last at least 2 weeks, and they also need to occur the majority of the days in a week. So that is a really important point to drive home when you're screening someone for depression, because I will have some clients that get confused if I leave that out and they say, "Oh, in the last 2 weeks, yeah, I have felt sad before." Well, that's not depression. Depression is in the last 2 weeks, have you felt sad, 12 of the 14 days, well, that now we're talking about a serious issue rather than, one day in the last 2 weeks I was really sad. So that's the kind of thing about looking for persistence. Are the symptoms lasting for 2 weeks, and are they lasting the majority of the days in the week? And just as my little reminder here, being sad can be normal, but being depressed is not. This applies to both you, who all of you in the webinar, to your family members, to your cousins, your aunts, your uncles, and to your clients especially. Being sad is normal, and that can be normal. You can feel down about a diagnosis. You can struggle with a change in life that, all of a sudden you have to take a medication every single day. I remember when I was diagnosed with low thyroid, which, so treatable. You'd think, oh, you're in medicine, Annie. You just were like, oh, yeah, they'll put me on thyroid hormone. I was really sad about it for a day or two. Like, I remember literally sitting in bed and crying just because I've never had to take a medication every day. I've been really healthy. And all of a sudden now, I had to take my thyroid medication every single day before I could eat breakfast. You have to wait that hour after you take levothyroxine to eat. And I was like, oh my goodness, it's the end of the world. Like, I will never be able to eat breakfast again. I have to remember to take this pill every single day. And it felt really overwhelming. I was sad. 2 days later, I got over it. I adapted easily. That persistence of still feeling sad, of not being able to adapt to something, of not being able to get over it, that's a really big indicator in your clients that there's something that you need to be screening for and looking at closer. And if any of these things apply to you as we're talking about this and you say, oh, yeah, you know what? Now that I think about it, I have been really tired and no appetite and I can't sleep and I feel really anxious and sad all the time for more than 2 weeks, more than most of the days. I ask you to go see your primary care provider, get help, get a screening, and see if this is something you are currently struggling with. You're not alone. A huge portion of the population worldwide struggles with mental health illnesses. High risk clients for depression are going to be people that are in nursing school and studying all the time and stress. I'm just kidding. Although big life stressors can be a risk factor for depression. So, you could argue that individuals in nursing school that are really struggling and working a job and doing clinicals can be at high risk. But really, the highest risk individuals are going to be those that have chronic illnesses, those that have just lost a loved one, those with a history of mental illness. So we know that, they struggle with anxiety, they struggle with bipolar disorder, and those that have substance use disorders. Those are all going to be clients that we know are already at a little bit higher risk for depression and that we want to make sure that we really screen and we don't miss. So talking about nursing interventions here, the biggest thing you can do for depression is screening. Screening. That's going to be a secondary prevention. Remember, screenings always fall under secondary, not primary, not tertiary. And it is going to be one of the most important things you can do for depression because it doesn't really matter if you never screen someone, you'll never catch it. So that is why screening is the most important thing, because screening is where we help diagnose clients with depression. You may not give that official diagnosis. If you're not a provider, you may not be the one to say and put it in their chart, that ICD-10 code that insurance companies use saying, hey, they have depression, but you will be the one to help screen and catch it. That is why every single client, even if they're giving me the biggest, most chipper smile in the world, they're wearing a shirt that says, I'm the happiest person on this planet Earth, I am screening them with a validated screening tool for depression. So don't forget that one. Next, you want to use therapeutic communication. Tell me more about how you're feeling. We never want to put feelings on someone. We never want to tell them how they're feeling or how they should be feeling. Like, it's been 6 months since your husband died. You should be feeling better by now. That is not therapeutic communication. It's not therapeutic communication to say, hey, you're sad, right? That's almost confirmation bias. We want to ask them, leave it open-ended, leave them the opportunity to tell you as much or as little as they feel comfortable with. And you can always ask follow-up questions. So remember, therapeutic communication is really big. In our health assessment course and in fundamentals, I dedicate entire modules in those two courses to therapeutic communication and making sure that our clients are comfortable. So we want to encourage participation in enjoyable activities, making sure that they have found something that they like to do, that they're doing that as frequently as possible. One of the first symptoms of depression is that they no longer get enjoyment. They are an artist. They've loved painting their entire lives. All of a sudden, they don't like painting anymore. Well, that should send red flags off in your brain. And we try to encourage those activities to try to get them back into something that they love. Someone that's depressed, if I had severe depression and someone told me to run, I hate running. I mean, that's not going to make me feel better. So don't encourage me to go on a bunch of 2-mile runs when I don't feel good. I love swimming. So encourage activities that you know your client likes to do. That is going to help boost mood and it's going to help intervene in depression. So, last practice question of the day, we're going to talk about depression here, obviously. A client with major depressive disorder states, I can't go on anymore. What is the nurse's priority action? Once again, that priority word. I hit you guys with these priority questions. A, notify the healthcare provider immediately. B, ask if they have a specific plan to harm themselves. C, encourage them to join a group therapy session. Or D, document the statement in their chart. Oof, guys, this is a hard one because I actually like all of these answers. Like, if you were asking me as a nurse, what I would do if a client told me I just can't go on anymore, I would do all of these. These are all things that need to be done. What are you going to do first? Remember that key word, priority action. So, give you guys a second to drop your answers in the chats below. Good job, guys. B, ask if they have a specific plan to harm themselves. This is like what we said. You want that therapeutic communication. You want to screen. You want to, screen them for it. They may have just said, this may have been in response to the fact that they can't, they're so worn out. They can't do any more laps around the building. Like it hurts. Their stitches hurt. They can't walk anymore. You want to screen for it. What does that statement mean to you? Do you have a plan to harm yourself? Do you wish you weren't alive anymore? We want to directly assess for suicidal ideation. That's going to be the priority. Imagine a client that is suicidal tells you, I can't go on anymore. And then you just book it. You just dash out there. You said, you know what, priority intervention, I have to go notify the healthcare provider. I'm out of here. Well, now you've just left a client who just told you that they wish they were dead. They don't want to be alive anymore. Alone in a room with a bunch of things that could be considered weapons that they could harm themselves with without following up. That is not therapeutic communication. It's not client safety. So remember, we want to first assess, directly assess, and then do the rest of them. Group therapy may really be helpful for them. You're definitely going to want to document the statement and what else they said after you followed up. So all those are good answers, but one of them needs to be done first. Lastly, guys, I just made this table for you guys about the key differences. There with the features of each of these things, the onset, the course, reversibility, and intervention. We know that depression and delirium can totally be reversed. Depression can be situational just for a couple months. Delirium can be just a couple days, until you drop the dose down or you treat that infection. Delirium fluctuates. Dementia progresses, and depression, honestly, fluctuates a lot too, but it can always improve with treatment, really. And so with that, this is a really good table, I think, to memorize, take a screenshot of. If you feel like you want a little bit more help with the triple Ds and how they vary and what we do as nurses to intervene. But as I put down here with this bracket, no matter what you're doing as a nurse to intervene, the thing you are always constantly doing is safety. Safety for your client is the number one priority, whether they have dementia and are getting disoriented, whether they have delirium and they're a fall risk, or whether they have depression and they may have suicidal ideation. Safety is our number one issue. It's our number one thing we focus on as nurses. And this is where we're going to end today, guys. This was a really good overlook at those triple Ds, dementia, delirium, and depression. But if you have other subjects you're struggling with and you just know that, you know what, I need just a little bit more, it's not something to be embarrassed about. I know that I took advantage of one-on-one tutoring when I was in nursing school. I took advantage of, group tutoring with a friend when I was in nursing school. Sometimes some subjects just come a little bit harder, and some subjects are just a little bit harder, and you need a little bit more help. And so with that, you will go ahead. You can sign up here using this QR code or go email us at nursingschool@archerreview.com. You can go to our website, archerreview.com, either one. and you can pick a tutor that you feel is the best fit for you. Everyone specializes in something different. Brandon, he's our dose calc guy. If you're struggling with math equations in nursing school, he's the guy for you. As I said, love primary care stuff, fundamentals, health assessment, geriatrics. That is my bread and butter. Jennifer, who we've got here on the call, she is maternal and reproductive. She teaches that course. She's amazing at that stuff. You just have so many different people that are great. Diane, I know, is great at mental health nursing, and I always struggled with behavioral health myself. And so I can't speak highly enough about each of these tutors because I work with them on a day-to-day basis. And so you can sign up here. If private tutoring, you feel like, oh, I don't want to be one-on-one, that feels like more than I need. We also offer small group tutoring where you're just in a small group with just a couple people. That can be really great for you, and you can sign up using a QR code as well. And we will just end there, guys. Just going back to this nursing school. If you want to hear more topics like this, if you want more courses, you can go ahead and sign up for that full nursing school. We give it to you in like a 2 or 3 year bundle with all 20 courses. You can just buy them for once for a really low price. We're trying to keep it as affordable for you guys as possible. I remember eating top ramen and struggling as a nursing student. So I want to make sure that that was at the forefront of our brains for you guys. You can sign up using this QR code here or using the link down below. Go ahead and reach out to us at nursing school@archreview.com if you have any specific questions. And